This is very nice. Okay, let me get my glasses. I can't read your name without my glasses. So, our next speaker is Dr. Anushree Shirali from nephrology. She's an assistant professor of medicine in the nephrology department. She's going to talk to us about onco-nephrology, managing cancer-related kidney disease. Thank you for coming.
Thank you, Dr. Lillenbaum, for that kind introduction, and thank you, everyone, for coming today. So I am going to talk about onco-nephrology. Just some disclosure slides. I am on the safety advisory board for nivolumab. I probably won't be talking about the drug, probably because we're going to run out of time. But I want to start out by saying that onconephrology has arrived in the kidney world. This is a special issue of CJASN, which is the premier clinical nephrology journal from a couple of years ago, which was really an educational issue on onconephrology. In addition, NEFSAP, which is a teaching a module for renal fellows, recently had an extensive curriculum for fellows and really attending nephrologists on cancer-related kidney disease. And finally, for the last 3 or 4 years, the American Society of Nephrology's annual meeting has hosted a pre-meeting symposia focusing exclusively on nephrology or cancer-related kidney disease. And as a letter to the editor in the JCO from last year submitted, the rationale for onconephrology is this. As the array of treatment options with novel agents has expanded, the need has been created for the expertise of onconephrologists who must be aware of the array of new chemotherapeutic agents and their potential effect on kidney function. So with that in mind, I'd like to propose my objectives for today's talk. One is to be aware of the epidemiology of kidney disease in oncology patients. Second is to review toxicity of chemotherapy drugs from a nephrocentric or really a nephron-centric perspective. And then finally, using, I think, what are well-established drugs that are well-established to cause kidney disease. I'm going to use a case-based approach to outline select management strategies for kidney-related toxicity. And if, which is a very big if, we have time at the end, I'm going to highlight some novel agents that I think will be soon associated with AKI. So this is a familiar graphic to most of you in the room, but it reveals hopeful news of the past decade that death rates are down across most malignancies. And while improved screening and detection of early disease may be partly behind this trend, I think targeted drug therapies over the last decade must also share the praise. As a result of the improved mortality statistics, there's, I think, a shift in oncology care, and I'm sure the clinicians here would agree, that it's not just acute anti-cancer management anymore, but also chronic care for survivors, including long-term complications. And one such complication of long-term care is AKI. While data on AKI in the cancer patient has long been limited by small size and non-uniform definitions of AKI, a large population-based study from Denmark from a couple of years ago has shed light of the burden of acute kidney injury in cancer patients. Using a large central patient database, authors investigated nearly 40,000 incident cancer patients and assayed for AKI stratified according to standard rifle criteria, which is our way of classifying AKI over a 5-year period. And what they found was an overall risk of AKI at 17.5%, that's for all cancers, with the highest rates of AKI being found in renal cell carcinoma and myeloma groups. Even for more severe AKI, identified either as injury, that's 2 to 3 times increase in baseline serum creatinine, AKI was fairly common at 8.8%. And then with the failure group at 4.5%, and these numbers increased as time went down from the original cancer diagnosis. And when AKI does happen, it's associated with bad outcomes. So this is single-center data from MD Anderson, which essentially showed that AKI is associated with a longer hospital stay and a longer total hospital expenditure. And more importantly, as AKI happens and as the severity of AKI increases, there is reduced survival time. This is very much similar to AKI in the non-cancer population, and it suggests that patients with malignancies are at very high risk for poor outcomes related to AKI. Finally, we know that AKI is a risk factor for chronic kidney disease in the non-cancer patient, and a retrospective cohort last year found that this is equally true in the cancer population. So this is a study by Deckers et al. Looking at 800 adult survivors of childhood malignancies, and they found persistent decline in eGFR, particularly in patients who had a history of high-dose cisplatin, history of high-dose ifosfamide use, presumably from prior ATN, as well as in patients with nephrectomy and abdominal radiation. So taken together, I think these studies on AKI and CKD show that cancer patients are facing a meaningful burden with respect to kidney disease, and this challenges us as clinicians to understand risk factors for AKI in the cancer patient. So when nephrologists look at AKI in any patient, right, we use the same classic way of categorizing that we all learned in medical school, really looking at the pre-renal, intrinsic, and post-renal compartments. And as you can see, AKI in the cancer patient is spread across all spectrums. What should jump out, however, is that chemotherapy is a potential cause in each category. And this may be indirect, for example, with pre-renal losses from chemo-related GI side effects, or as a few case reports have described, bladder outlet obstruction from intravesicular thrombi formation with cyclophosphamide use. But the most worrisome aspect is direct or intrinsic nephrotoxicity from chemotherapy. And it turns out that cancer patients are frequently exposed to potentially nephrotoxic studies. So this is data from the French IRMA study, in which Launay Vacher, who's a French pharmacist, presented observational data from multiple cancer centers from across France, and found that the majority of drugs employed as anti-cancer agents in this cohort, even in patients who already had a reduced GFR, were potentially nephrotoxic. While this doesn't mean that an adverse renal effect took place in every case, it does suggest that the potential of AKI is certainly there, particularly if there are other risk factors for chemotherapy-related AKI. And what may some of these other risk factors be? Well, they can be broadly categorized as drug, patient, and kidney-related effects. Or factors, and these factors can really crosstalk to produce an undesirable outcome, in this case, AKI. So in considering these factors, one can, for example, understand how an older patient with pre-existing CKD who has cisplatin-related nausea, vomiting, or diarrhea, and is also on NSAIDs, may be at risk from the inherent nephrotoxicity of cisplatin. So understanding other risk factors for AKI is just as important as understanding chemotherapy itself. So I confess that I'm somewhat in awe of oncologists. I have yet to acquire the gray matter to look at this potpourri of letters and recognize that for the oncologists in the audience, this is a language unto itself. To the nephrologist, however, this brings up more questions than answers. So while oncologists may view chemotherapy in a certain way, nephrologists tend to take a nephron-centric view of chemotherapy. So in such a view of chemotherapy, we look at where in the nephron certain chemotherapeutic agents act and what kind of clinical syndrome these therapies result in. So these may be electrolyte imbalances such as hypo or hypernatremia or hypomagnesemia seen with a variety of agents. Or they may be tubular effects that result in ATN, ATN or crystal nephropathy, or glomerular effects that result in thrombotic microangiopathy and FSGS. For the sake of today's talk, I'm going to just focus on those drugs that cause ATN, TMA, and crystal nephropathy, particularly because these are the clinical syndromes that result in acute kidney injury. So with this in mind, I'm going to start with a case. These are based on cases that I've received either in clinic or the inpatient consult nephrology service has received. So this is a 65-year-old male with stage 3B non-small cell lung cancer and hypertension who's hospitalized after clinic labs note increased serum creatinine from a baseline of 0.6 to 2.3. So he's clearly has AKI. A week ago, he received full dose cisplatin as part of cycle 3 of alternating cisplatin and vinblastine. He's also receiving radiation. His other meds include as needed celecoxib, a selective COX-2 inhibitor, lisinopril, and amlodipine. On exam, he's afebrile. His blood pressure is 160 over 100. He's got clear lungs and bilateral lower extremity edema. When the nephrology group is consulted, they note increased creatinine as shown, without any electrolyte or acid-base abnormalities. His glucose is normal. His UA is significant for some protein, some glucose, and a spot protein creatinine ratio of 0.5. When the nephrologists take a look at this at the urine for urine sediment, they see coarse granular CAS. So this is chemotherapy-associated induced ATN. It has been classically associated with cisplatin, but also with ifosfamide, pemetrexed, and less so with zoledronic acid and pentostatin. And clinically, this is AKI, which can be severe depending on the dose given and other risk factors for AKI. And when we biopsy these patients, what we would classically see is flattened epithelium of the renal tubules, nuclear dropout, dilated tubules, all pointing to dying tubular cells, and we may also see interstitial edema. So cisplatin is probably the platinum compound most in use, a prototypical platinum compound. And as I said, the clinical presentation is reversible dose-dependent AKI. With prolonged use, the AKI episode may result in CKD. There are other manifestations of cisplatin nephrotoxicity, including Fanconi syndrome, salt wasting, hypomagnesemia, and nephrogenic DI. And as I'll show you in a slide later on, the nephrotoxicity of cisplatin is greater than carboplatin or oxaliplatin, and some of this may be just due to the way we dose these other drugs, but it's also directly related to how cisplatin enters proximal tubular cells. So prevention and therapy. So the primary means of prevention is aggressive saline diuresis. One thing that's been of interest to me, and I'll point this out a little bit later when I talk about the mechanism of toxicity, is the potential use of cimetidine to counteract the proximal tubular uptake of cisplatin. This has often been proposed, and there's some in vitro as well as animal in vivo data to suggest this might be effective, but to my knowledge, this has never been tried in the clinical world. There have also been suggested therapies. These are really antioxidant therapies, including glutathione analogs and sodium thiosulfate, but really the side effects of these other agents have limited that modality. Dialysis is for uremia only. There is no role for drug removal with cisplatin. This is a systematic review that essentially shows what I'd mentioned before, that when compared to patients who are receiving carboplatin, there is a higher risk of nephrotoxicity measured by AKI with the use of cisplatin when compared to carboplatin. So how does cisplatin induce ATN? Well, the cis in cisplatin refers to a chloride group at the cis position of the parent compound, and that chloride group allows uptake via the organic cation transporter, which is on the basolateral surface of proximal tubular cells. Once inside the cell, cisplatin can induce a variety of pathways that stimulate inflammation, reactive oxygen species. The downstream result of all of this is renal tubular injury, resulting in apoptotic and necrotic pathways. Clinically, this results in acute kidney injury as well as those electrolyte abnormalities that I mentioned earlier as a result of isolated tubulopathy. Ifosfamide is another drug that causes ATN. Ifosfamide, as you may all know, is structurally related to cyclophosphamide, differing really only in the position of the second chloro or ethyl chloride group. But the tubular toxicity is unique to ifosfamide because it alone can enter the organic cation transporter channel into the proximal tubular cell, where cyclophosphamide cannot. This essentially results in ifosfamide being degraded into toxic metabolites inside the proximal tubular cell, resulting again in the clinical syndromes of AKI from ATN or isolated electrolyte abnormalities from tubulopathies. The clinical presentation is usually non-oliguric AKI that's reversible with cessation of drug therapy. Or you can also see a Fanconi syndrome with phosphate and potassium wasting. Nephrogenic DI has also been proposed, and there's some data from the pediatric literature, which I'll show you subsequently, that shows CKD with long-term use of ifosfamide over a certain threshold. Prevention treatment, again, is focused on saline diuresis, correction of underlying electrolyte abnormalities, and for persistent nephrotoxicity, suggestion has been made in the pediatric literature to limit cumulative doses. And this is essentially old data from Skinner et al. This essentially showed that severe AKI, shown in the dark black groups, is really associated when total ifosfamide dosing, lifetime dosing, exceeds about 85 grams per meter squared. This is in the pediatric population. Pemetrexed is a methotrexate analog. It is taken up by cells, including proximal tubular cells, via the folate carrier. Once inside, it's polyglutamylated, which essentially traps it inside the cell. And there, it has downstream effects that, in the end, prevent cell cycle and cell division. There are case reports with short-term use of AKI, often with electrolyte imbalances, but more interestingly, with long-term now maintenance use of pemetrexed in patients, progressive tubular injury with chronic tubular interstitial changes has been noted, resulting in CKD. So this is data from Memorial Sloan Kettering by the nephrology group there that showed patients who had been on maintenance pemetrexed therapy for median of about a year or so, that essentially showed that clinically they had CKD, and when biopsied, showed interstitial fibrosis as well as evidence of tubular injury with dilated renal tubules. Our second case is one of a 56-year-old female who's diabetic, has retinopathy, has stage 4 colon cancer, who begins combination therapy with bevacizumab, oxaliplatin, 5-FU, and leucovorin. She's well until a follow-up visit with her oncologist, when her usually controlled blood pressure is elevated at 150 over 100. She's complaining of some shortness of breath, some malaise, and some anorexia. On exam, she has lower extremity edema, but her lungs are clear. And her labs are notable for acute kidney injury, rising from a baseline of 1.1 to now at 1.7. Anemia that's more severe than she's had in the past, and thrombocytopenia. Urinalysis, which was previously +1 or +2, is now at +3. She's got some blood, and on sediment, she has 5 to 10 RBCs per high-powered field and no CAS. So if you were the nephrologist taking care of this patient, you would ask for a blood smear to be taken. In this case, what was seen was occasional schistocytes. Now, in this patient, clinically, this appeared to be a TMA, but if you were to biopsy this patient, this is what you would see. Essentially, this is a renal glomerulus, and I probably should have put in what a normal glomerulus looks like as a comparison. But essentially, what you're seeing is swelling and expansion of the mesangial space. These are thrombi that have now occluded endothelial cells, and essentially, what this looks like is non-pregnant preeclampsia. Again, highlighting the endotheliosis, mesangiolisis, bloodless glomeruli, and what you saw was the intravascular thrombi. So chemotherapy-induced TMA has been seen with VEGF receptor, as well as TKIs, but it has also been described with gemcitabine and cisplatin use. And the clinical feature can be AKI, but really what precedes the AKI and what really needs to be paid attention to by both nephrologists as well as oncologists is new onset or worsening of underlying proteinuria and new onset or worsening of underlying hypertension. So the oncologists in the room are really familiar with the anti-angiogenic features of anti-VEGF and TKIs. But it was recognized early on by the nephrology community that bevacizumab in particular is associated with an increased risk of proteinuria and hypertension. So this is a systematic review done by Chirag Parikh, who's a nephrologist in our section, back in 2007, which essentially showed that a relative risk of worsening blood pressure control with low dose as well as high dose use of bevacizumab. And similar data were shown for proteinuria. So how does bevacizumab induce TMA? So these were teased out with an elegant set of experiments done by Susan Quaggan, who's a nephrologist and a physician-scientist, when she was at the University of Toronto. And what she did was develop a mouse model which used a conditional conditional knockout of VEGF in particular cells. So in essence, what she did was feed doxycycline to mice who, and using a TET-on model, was able to get site-specific deletion only in podocytes of these mice. So there was circulating VEGF. All the other cells that were supposed to have VEGF had VEGF except for renal podocytes. And what she essentially is showing here is that in the presence of doxy, she was able to get an inducible knockout of VEGF in the renal glomerulus. And what did she see in these mice? Well, upon necropsy, she's recapitulating what I showed you previously. So this is a renal glomerulus from a mouse, and she's showing you mesangiolisis, endotheliolysis, some deposition here, and then thrombi. When you take a blood smear from these animals, you're seeing schistocytes, and this is essentially showing renal thrombi. And this essentially recapitulates what she found in patients in their renal clinic. So just as in the murine model, she was able to show renal thrombi, mesangiolisis. Similarly, in patients receiving bevacizumab, findings could be recapitulated. So this essentially leads to a model of how VEGF is acting in the kidney. So in the normal renal glomerulus, podocytes are locally producing VEGF. That VEGF comes down to the renal endothelium, providing structural integrity for renal endothelial cells. So in the case of VEGF knockout animals, when local production of VEGF is not present, it leads to endothelial injury and a thrombotic microangiopathy. And a similar syndrome can be seen with clinical use of bevacizumab. So anti-VEGF induced TMA, as I said, reversible dose-dependent hypertension that cannot be underlined enough. This is really the initial first clue prior to any changes in creatinine. The same can be said of proteinuria. The deterioration in GFR can be more subtle, and long-term outcomes are unclear. This is, I think, some intriguing data where there's some suggestion, particularly in the lung cancer literature, that hypertension, proteinuria onset may actually be a biomarker for anti-tumor activity. The prevention and therapy, well, I think what goes without saying is that you should have at least baseline protein creatinine measured and periodic monitoring so you can catch these patients early. If hypertension control is needed, RAS inhibition, although there's no evidence to suggest its use, but as an antiproteinuric and antihypertensive measure makes sense. And then in the case of worsening GFR, a case should be made for drug withdrawal. Gemcitabine-induced TMA had a very low preclinical incidence of about 0.015%, but subsequent single-center data, this was from Beth Israel Deaconess Medical Center, showed that the actual incidence was a bit higher. And the presentation can really be insidious onset of renal insufficiency, but if you were to take a look back, it can be preceded by worsening hypertension, proteinuria, and edema. The treatment is withdrawal of drug. there is actually, even though we all reflexively do it, no proven role for plasmapheresis because an offending antibody has not yet been identified with use of gemcitabine. And the theory really is that this might be direct endothelial injury from the drug. So the last case is that of a 78-year-old female with a history of osteoarthritis who has a baseline CKD and is admitted for IV methotrexate use for osteosarcoma of her left distal femur. She gets dose-adjusted methotrexate and gets leucovorin appropriately and is receiving alkaline diuresis. 2 weeks later, she's admitted for redosing, and a nephrology consult is requested when the following day's labs reveal a creatinine of 2.2. Her exam is essentially normal. She's making a good amount of urine. Her creatinine is as above, and her urine analysis shows an alkaline pH, and her serum methotrexate is as shown. If you were to do a urine sediment, you most often would see nothing. Every now and then you might get lucky, as my colleague Ursula Brewster did, in actually finding methotrexate crystals on urine sediment and solidifying the diagnosis. So chemotherapy-induced crystal nephropathy from methotrexate hits the distal nephron. This is where methotrexate crystals will cause tubular occlusion and AKI. And if you were to biopsy these patients, you can see methotrexate crystals within the renal tubules. Clinically, this is AKI, and the histology is tubular injury. Methotrexate works similarly to pemetrexate with respect to entry into the cell and downstream effects. The clinical presentation, again, non-oliguric, reversible AKI, overall incidence from the osteosarcoma trials is about 2%, and it's characterized by high serum methotrexate levels according to nomogram, despite leucovorin rescue. The prevention is avoiding potentiating nephrotoxicity. So probenecid and aspirin have been suggested as agents that might interfere with renal excretion. I think the aspirin data is a little fuzzy, and I think it's really more with high-dose aspirin use that we don't clinically use today. Alkaline diuresis with a goal urine pH of greater than 7, and leucovorin is the sine qua non for folate replacement. The treatment is high flux, underlying the high flux hemodialysis, where a larger pore size will effectively, of the dialyzer, will effectively remove circulating methotrexate. And what's new on the horizon is now FDA-approved carboxypeptidase G2, or glucarbidase, which is essentially a bacterial recombinate enzyme that cleaves methotrexate into non-toxic metabolites. And the advantage may be, again, there's no real good data to support its use, and it is an expensive drug and hard to get your hands on, being a non-formulary drug. But the advantage may be, whereas high flux hemodialysis is often associated with a post-dialysis rebound in serum drug levels, CPDG2 seems to have a sustained decline in levels. I think I'm going to just skip over this last part and just entertain any questions you may have.
Thank you.